I am sharing my screen now. Great. So just so people are aware, we have had to date 259 people who've been diagnosed with COVID-19, which included 6 in the month of October. As you can see from this slide, um, we really struggled at the beginning with 140 people in April, down to 50 in May. And, we have flattened that curve. And I think it's essential that, the people continue their practices. And I'm really grateful to DC Health for the technical assistance they're providing so that we can keep that number low down there where it is now in October, or even down lower, ideally to 0. By placement type, to date, there have been 114 people in supported living placements, 27 in residential habilitation, 2 in a nursing home, 25 in their natural homes, 87 in an intermediate care facility, and 4 in a host home who have contracted COVID-19. I think it's helpful also to understand sort of, those numbers sometimes jump out when you hear the very high number for supported living. In terms of the percentage overall, the percentage of people in ICFs who've contracted COVID-19 has been almost 30%, as you can see. For people who are seeing the screen, it's the blue bar. The percentage of people in residential habilitation placements is 24.5. Percentage of people in supported living, 12.2. Percentage of people in natural homes, 2.7. We actually now are getting data directly from the Medicaid system so that we can see when people have been tested. So our natural home number went up a little, but it still is staying percentage-wise very low. Overall, as people know, it's about 10% who have contracted COVID-19. And then really significantly, in terms of the people who have contracted it, in terms of those serious outcomes for people, 16% of the people who contracted COVID-19 in intermediate care facilities died from COVID-19. 20% of the people who we identified as having contracted COVID-19 in their natural homes died. 7.4% in residential habilitation, and almost 10% in supported living. So it's also interesting to see, I always go over each month, we currently have 2 people hospitalized in the month of October. Of the people who contracted COVID-19, 2 required hospitalization. 1 person has been in a long-term care facility recovering still from the effects of COVID-19 and is still there. 1 of the 2 from October has already been discharged. And I have always reviewed, I try to give enough of the information about deaths to be clear about the numbers. 34 people who contracted COVID-19 have died to date. Of those 34, however, we did get, and as you can see from this chart, the vast majority of those were in April. Out of 34, we had 18 deaths in April and 8 in May. Out of those 34, however, 2 have already been confirmed by the Office of the Chief Medical Examiner to have died from causes other than COVID. We also have 5 other people that they are still looking at, where they're doing the investigation of those 5 to determine what the cause of death was. In those instances, the person had been determined to have recovered from COVID and subsequently died. And so they're trying to understand if COVID was an underlying cause of their death. So if you exclude those 7, you can see that of cases where we have confirmation that it was a COVID diagnosis that caused the person's death, there's only the last death that we know for sure was directly related to COVID occurred in July. And so we had 18 in April, 8 in May, and 1 in July. And we are still awaiting, as I said, a final determination about the remaining 5. Lastly, I'll just let you know that in terms of provider staff, There was one additional provider staff person, although not someone who works directly with the people we support, who was diagnosed with COVID-19. And so that brings our total of provider staff to 350, with 30 people who've worked in more than one location and 8 deaths. And now the challenge is for me to stop sharing, although, so now I'm hoping that you can just pull this up. Oh, there we go. It was on that other screen. There we go. So with that, I will turn it over to Daryl Hawkins, who I believe also has some slides to share so that she can talk about, provide some information from DC Health.
And as you mentioned, I think I have slides because I know that folks can, it's easier sometimes to see the visual than just to hear the voice. I want to also underline what Director Reese kind of just showed data-wise. It's such great. It's great to see the cases going down over time. But also, I just want to remind everyone, this is, if it feels like a marathon, because it is a marathon, the response. And I just want to say thank you for continuing to obviously do the efforts that have shown us that it has paid off in the slides that Director Reese showed. And hopefully we get to, there's always room for improvement, and we're really here to support you. And so part of that is, I want to talk about the PPE requirements from the DC Health guidance. It's found on coronavirus.dc.gov, and it's required personal protective equipment for healthcare facilities. So it encompasses much more than just this setting, but I will talk about this guidance, and if anyone has any questions, I can, as always, answer after. So just every presentation, I always kind of go over how COVID-19 spreads. So still primarily thought to be spread through close contact with one another, through respiratory droplets, and it can be sometimes spread through rarely airborne transmission. And we'll talk about some of the things that can make it airborne, but also it can be possible to get COVID-19 by touching surfaces, objects that the virus is on. So all of these things and how it spreads really kind of underline the reasoning for some of the PPE requirements that I'm about to go over. But one of the things that I often get questions about is, how do I interpret DC Health guidance? So just for all the guidance that you see on coronavirus.dc.gov, I think it's helpful to point out that any guidance item or bullet point that has the terms must, required, or is an action wording, such as clean and disinfect all non-dedicated equipment, that's an action wording, is a DC Health mandate. However, any guidance that has the term should, recommend, or consider, it's something for you to strongly consider implementing, but is not required as mandated by DC Health. And sorry. So as I always want to mention, that you as a facility can require more stringent measures in your policy and procedures than what DC Health guidance mandates or requires. However, it cannot be more lenient than what DC Health mandates or requires through those wordings like must, require, or action words. And I'll go over this again, this 7 elements of an effective and sorry, another thing that is also a mandate is will. Facilities will is also a mandate. So this image on really how to effectively have a good compliance program is really just to underline that guidance is one thing, but implementation is the tough part, and that's really a lot on your facility, and there's a lot of different things that you can do to ensure that that happens in your facility. So to talk about the required personal protective equipment, this guidance, required personal protective equipment for healthcare facilities, it applies to any facility, entity, or individual that provides services, healthcare services, that is either licensed by DC Health or functions as an independent private practice through a certificate of need. And this includes, but is not limited to, all these different settings. And I've highlighted the ones that are, for those of you here, intermediate care facilities and Chapter 34 and 35 community residence facilities. These requirements should also be strongly considered if you are not those that were highlighted in the previous slide, but it is not a mandate or a requirement for those settings. But you could strongly consider these guidances to apply to your policy and procedures in your setting. So as I go through, some of the PPE guidance, kind of requires me to talk about what the definitions are. We get a lot of questions across all different settings, what healthcare personnel entails. I know that this is a picture, an image of a child, but I think that I've used this in different settings, even if they don't have pediatrics, just to underline what we mean by healthcare personnel. Healthcare personnel are all paid and unpaid persons serving in these healthcare settings who have the potential for direct or indirect exposure to patients or infectious materials. And in this case, I know there's terms that say patients here, but remember, this guidance is really for all different healthcare facility settings. I know that we don't refer to our persons supportive as patients. So just keep that in mind. And then also, this can include contractors, agencies, volunteers, therapists, private duty aides, nurses, direct care staff, etc. So as I said, if it's a family member, they're not healthcare personnel. The person being supportive is not healthcare personnel. However, even this image of this clown who is coming there as kind of a volunteer is going to be considered a healthcare personnel, even though normally you don't think of them as healthcare personnel, but basically all unpaid and paid and unpaid persons serving in that setting who has potential for direct or indirect exposure is considered healthcare personnel as defined by the guidance. And then the next question that we get, because some of the guidance pertains to wearing certain PPE in patient/resident care areas, what does that mean? It's all areas where care is rendered, where diagnostic or treatment procedures are performed, or anywhere there is potential for patient or resident encounters or person-supported encounters. So that means any place that a resident or person supported can access. So living room or area in your residences where person supported can be, the bedrooms, of course. And the only places where this would not apply would be any areas where it's only for staff and none of the person supportive can go there, and it's clear and they never are in that space. And you will not encounter them in that space. That is not a patient resident care area. Okay, so now going to what is required. And we've talked about this in many different calls, so this should not be new, but all healthcare personnel, as I previously defined, must wear a medical face mask. So that's either surgical or procedural mask while in the facility where those services are provided. And in addition, for universal eye protection, healthcare personnel must wear eye protection in those patient care areas as I defined them, and in any area if where there's staff where 6 feet of distancing is unable to be maintained. So even in those places where you might not encounter a person supported, maybe it's a staff designated area, if it's a small space and you have multiple staff in there that they cannot be 6 feet apart, we're also going to, a healthcare personnel must still wear eye protection in those areas. So what are the different masks, right? So cloth face coverings, they are not considered personal protective equipment. So healthcare personnel should not be wearing these while in your facility. Medical face masks, they are personal protective equipment. However, they should not be worn if you are, if your staff has been fit tested. They should not be worn during aerosol generating procedures, and I'll go over that in detail in the upcoming slides. And then respirators, they are considered personal protective equipment. They should only be worn by those as that are medically cleared and fit tested as part of a complete respiratory protection program. And they must be worn during aerosol generating procedures that, again, I will cover in the upcoming slides. A note with masks for mask with valves. So here's two examples of mask with valves. I'm sure many of you have already seen this out in public, but there are cloth masks with valves. There are respirators with valves. Exhalation valves make it easier for you to breathe when you're wearing it. However, they should not be used. They must not be used because it may allow unfiltered air to escape. They're not used for, they do not provide source control. So masks with exhalation valves do not provide source control, and they must not be used in the facility. So some rules about masks that the guidance outlines. Do not double mask or wear a mask under a respirator. Face shields must never be worn as a substitute for mask. I'm sure some of you have also seen that in public where people are wearing face shields but not a mask. That is not, face shields are not a substitute for mask. And then finally, healthcare personnel must remove their face mask at the end of the shift and change into a cloth face covering or their own mask when they leave your facility. So here's a great example that we've seen. I actually saw in a facility of a sign that they had right at their exit to remind their personnel, their staff, to remove and dispose of that mask. Another word about eating and drinking, because thinking about when do your staff take off their mask when they're working in your facility. So one, make sure that they do not eat or drink with the persons being supported, because then they would be unmasked around those that you are trying to protect. And then in situations where the healthcare personnel are temporarily unmasked, so let's say they're going to eat in the dining room of the residence, please make sure that, remember at that point, social distancing is critically important. So stagger the meal times. Have your staff not eat at the same time if feasible. And if it has to be that way, make sure that you block off or to remove some of the chairs. Make sure that everything is 6 feet apart if you had no other option and they had to eat at the same spot. But I think in many of your settings, you can probably stagger those break times so that it even reduces that risk from staff to staff member. Okay, a word on eye protection. What do we define as appropriate eye protection? CDC defines eye protection as either a face shield or goggles that are indirectly vented that fit snugly from the corners of the eye across the brow, and then face shield should cover the front and sides of the face and wrap around the face to the point of the ear. If your setting, your facility has you cannot find any face shields or appropriate goggles, then you're at crisis capacity. If you are, please reach out to DC Health and Medical Coalition and inform us that you're at a crisis capacity for your eye protection. If you are in crisis capacity, then you are able to have this alternative. But again, make sure to reach out because the face shield and the indirectly vented goggles is appropriate. Crisis capacity for eye protection are strategies to use when you do not have any of those available. So you could consider using safety glasses without gaps on the side, but that's only if you have shown that your facility has not been able to purchase excess face shields or indirectly vented goggles. And again, if you're at this level of crisis capacity for your PPE, please reach out. We should know that you're in that capacity so that we can see if there's anything we can do to help you. Regardless of where you're at, even if you're at crisis capacity, there's certain eye protection that is not acceptable at all. And that includes safety glasses with gaps or does not cover the sides of the eyes. Any directly vented goggles, what that means, if you look at these goggles, there's holes at the top, right? That is a directly vented goggle. That should not be used. And eyeglasses are never considered eye protection, even when there are those things on the side of them that I've seen people try to purchase. So this is a really good imaging to kind of hit home why we are requiring indirectly vented goggles and face shields. So I talk a lot about like pretend that you're spraying paint what would happen, and that's how you can determine if that eye protection is appropriate. You can see here in this demonstration with a splash how indirectly vented goggles and a face shield really protects those mucous membranes around the eyes. And you can see even in that the second column, you can see what a safety glasses that is not appropriate, how that doesn't really protect from splashes, and how eyeglasses don't protect either. Okay, so now we're going to talk about what are the PPE requirements for different clinical scenarios. What are healthcare personnel, what must they wear while they're in the facility? One, if COVID-19 is not suspected in any of the persons supported in those settings that I had mentioned before, healthcare personnel must wear a medical face mask and appropriate eye protection, whether that's a face shield or indirectly vented goggles, as we just covered. What about if there's an aerosol generating procedure? All healthcare personnel must wear the following PPE during aerosol generating procedures for all persons being served, regardless of their COVID-19 status. So even if they are not symptomatic for COVID and they're not COVID positive, this must be worn during, PPE must be worn during aerosol generating procedures. So that includes a gown, one pair of non-sterile gloves, an N95 or equivalent respirator if your staff have been fit tested for it, and as part of a complete respiratory protection program, and eye protection. And what are aerosol generating procedures? So we've talked about this before. Examples of aerosol generating procedures include some of these, like BiPAPs, CPAPs, that's types of non-invasive ventilation. So some of the persons you support might wear one of these when for sleep apnea, for example. Open suctioning of airways, anything that induces sputum, nebulizer treatment administration, high flow oxygen delivery, any cardiopulmonary resuscitation or manual ventilation are just some of the few examples of aerosol generating procedures that you might encounter in your setting. So a couple of reminders while we're on the topic of aerosol generating procedures. Do not perform aerosol generating procedures in common areas of the residence. So for example, not in the kitchen, not in the dining room, not in the living room. If other persons, so for example, if they're in a room and they have a roommate, you want to try to avoid having the roommate, you want to have that roommate not in the room during that aerosol generating procedure if at all feasible. So there's caution on that. And then you want to perform aerosol generating procedures in a well-ventilated room. So some bathrooms sometimes don't have windows like in this image, so you don't want to do it there if you can avoid it. Ideally, you'd want to do it in that person's room with well-ventilated room. So opening a window, for example. And then after you do the aerosol generating procedure, if other persons supported have to go into that room, you want to make sure that you clean and disinfect that space and make sure that that you have good ventilation in that space before letting other individuals in that room after an AGP. Okay, so the next PPE requirement really talks about persons who are under observation. And what do we mean by that in our guidance? Observation really refers to persons who are asymptomatic, so they don't have any symptoms, and they're quarantined because they were newly admitted to your facility or your setting from another high-risk setting. So if they are newly admitted, they should be quarantined for 14 days, even if they're asymptomatic, and we call that observation. So during observation, what is the PPE required to be worn for those individuals? All healthcare personnel must wear the following: some kind of respiratory protection, so either an N95 respirator or a medical face mask is appropriate, eye protection, gown, and one pair of non-sterile gloves. And keep in mind that the gown and the gloves at minimum should be removed when, let's say you're caring for someone under observation and then you have to leave that room and care for another person being supported. You should remove that. Additionally, eye protection or a medical face mask or a respirator, if they are visibly soiled and contaminated, should be removed as well. What if the person you are supporting is symptomatic with COVID-like symptoms and they're awaiting their test results, or they test positive, or under quarantine because they were exposed to someone who was positive? So again, if they're symptomatic, if they test positive, or under quarantine, even if they're asymptomatic because of a direct exposure to a known positive individual, then healthcare personnel caring for them should wear respiratory protection like a mask, a face mask, or a respirator. We want to, in this instance, we want to, if you don't have a lot of respirators, and I know that's tough to find, you can reserve respirators for aerosol generating procedures and use a face mask. That's why there's an or there. And then eye protection is required, gown and gloves. So again, to reiterate, if a person is symptomatic with COVID-19-like symptoms, is awaiting test results for that, or has tested positive, or under quarantine because of a direct exposure to a known positive individual, this is the PPE that is required for healthcare personnel to wear. General PPE information. So just as a reminder, personal protective equipment. It is called equipment because it needs to be worn correctly and used correctly for it to actually protect the person wearing it. PPE alone is also not a substitution for social distancing. So just because I'm wearing my mask and my eye protection does not mean I should be within 6 feet of other staff that I work with, for example. Obviously, in the care that your DSPs or other direct care providers provide to the persons being supported, they might need to be within 6 feet, which is why PPE is also important to protect them. So PPE must only be worn in locations where it is required and appropriate. So for example, we shouldn't wear gloves walking around the facility and wearing it the whole entire time. So we wear gloves when we believe we are going to come in contact with bodily fluids, or in those instances that I mentioned in the previous slides. And remember that we never wear the same gloves caring for different persons. We always take it off and do hand hygiene. We always perform hand hygiene before putting on, meaning donning, and after taking off or doffing PPE. So before you put on any PPE, you should do hand hygiene. After you remove any PPE, you should do hand hygiene. So what does that mean? You really should have hand hygiene products like alcohol-based hand sanitizer available to all of your staff. Very, frequent use is really due to you providing it, right? So environment is, I like the quote, environment is an invisible hand that shapes behavior. And if you make it readily available, people will readily use it in the frequency that you want them to use it. And any reusable PPE, like for example, if you have reusable eye protection, it must be properly cleaned, decontaminated, and stored after use and between uses. And CDC does provide guidance on how to properly, and we've talked about that before in these calls, how to appropriately clean and disinfect eye protection if you are reusing that. So as I promised, that image is here again. One of the requirements in the guidance is that employers of healthcare personnel must provide comprehensive PPE training to employees, because again, remember, PPE is equipment and it's only effective. It's as effective as people using it appropriately. So it's important to provide them training on that. And happily, the CDC's website does have free training videos that can be found at this on their website as well. Employers of healthcare personnel must conduct routine audits of PPE compliance, specifically for, but not limited to, masks and eye protection, to help inform your educational efforts around the appropriate use of PPE. So these audits should include assessments of PPE use that are specific to preventing the spread of COVID-19. So that's why this image is really important. So we have guidance but I know that really our guidance is really only as good as your integration into your policy and procedures in your facility and your open lines of communications to that really crucial frontline staff, direct care personnel, the training and education that you provide them to do it properly. And then on your end, really monitoring and auditing that they're doing that in your locations will help you understand how to improve their compliance so that they can protect themselves, their loved ones, and the persons that you support. So as we always mention, our guidelines continue to be updated as the science evolves, as we learn more information, as the outbreak evolves. So as I always say, please visit coronavirus.dc.gov regularly, look at the health guidances, click on the phase 2 tab, click on the health guidance tab, check that regularly, make sure that, and looking at that guidance, make sure that your policies and procedures are also updated to reflect the minimum requirement by DC Health. And I just want to, again, thank all of you as Director Reese does and as we do. We thank you for really, doing all that you have been doing. It certainly looks like it's paying off based on what Director Reese has shown. Like I said, this is a marathon. I'm a basketball fan, and I'm also from Miami, so I'm a Miami Heat fan. And what I will say is Jimmy Butler, who's a player on the Miami Heat, he has the work ethic I think a lot of you guys have, meaning we don't improve unless we continue to push through, even when you are getting a win, right? So we don't stop training, we don't stop the efforts. The efforts that you're doing now, keep those numbers low, which shows us that we're protecting those that we're serving, and we're protecting our frontline workers and the whole of DC community. So really, the effort to keep those numbers where it is commendable, and it continues. So please stay vigilant. And we're really, I just want to say from DC Health's perspective, we're here to support you in doing that work. We know that the bulk of it is really on all of you, but we're here to really help support you in doing that. And I know that many of you might have questions, but I do want to use this opportunity to now introduce my colleague from DC Health, Healthcare Facilities Team, Andrea Coker, who's going to talk a little bit about our pilot program, which in ICFs, which again is part of us really wanting to support all of you to continue these efforts during this, pandemic. So, Andrea.
Hi, good afternoon. My name is Andrea Coker, and I'm a technical assistant team member with DC Health Epidemiology and Surveillance Branch, COVID-19 Emergency Response Team. We also have our co-workers here, Rashonda Hammond and Nelson Vanucci. So DC Health COVID-19 Emergency Response Healthcare Facilities Team, in collaboration with CDC, is piloting an infection control and prevention pilot program for intermediate care facilities in the district. While COVID-19 has affected all DDS settings, DC Health is piloting this program in the ICF settings because the persons served in the ICFs generally have more medical complex needs and have more serious outcome related to COVID-19. DC Health is piloting this novel program to assess the feasibility of using remote or virtual infection control assessments, which are tele-ICARs, to ICFs in the district. While the tele-ICAR is used extensively in other subacute settings, this will be the first time it is applied in the ICF settings with CDC support. Tele-ICARs usually use voice and or video conference devices as an alternative to the in-person infection control and prevention assessments and consultations. During the tele-ICAR, facilities will discuss their current policies around personal protective equipment, hand hygiene, environmental cleaning and disinfection, screening, and notification of COVID-19 with DC Health subject matters experts from our team. The goal of this pilot program is to provide an infection control resource for ICFs that will enhance and improve infection control practices, And additionally, it will also help us explore the feasibility of expanding the tele-ICAR to other ICFs in the district. This program will recruit a target of 10 to 12 ICFs over the next 2 months, with the goal of recruiting one location from each of our ICF providers in the district. Our main intention is providing a tele-ICAR for one location for each of the ICF providers, is that this can provide ICF providers knowledge on infection control practices that they can implement not only in that one location, but in all of their locations. If you are an ICF provider, we will be reaching out to you in the coming months to participate in this pilot project. Once again, as Daryl said, we thank you for everything that you do for your continued work to keep the persons you support, your staff, and the DC community safe. And we look forward to providing this resource to ICF providers as part of our continued efforts to partner and support the DDS provider community. If you have any questions after this call, please feel free to email coronavirus.hai@dc.gov.
Thank you very much. So during your presentation, Daryl, we did get a couple of questions. So if we have time now, I'd like to walk through some of those. There was one typed in that I responded to. Someone asked, did the PPE guidance refer to ICFs or waiver placements? In fact, as indicated in the PowerPoint, it applies to all DC health licensed facilities in the district. So that would be intermediate care facilities and residential habilitation placements. And as the first couple of slides indicated, it's required in those settings, and then it's guidance that should be considered in other settings, such as supported living. And then there was a question, if a person is COVID positive and requires an aerosolized generating procedure such as CPAP while sleeping, what measures should be taken to keep staff and other residents in the home safe? Okay,
great, thank you. So in that instance, if they're wearing a CPAP, during and they're COVID positive, really anybody with a CPAP, even if they're not COVID positive, if they're COVID positive, for sure, they should not be sharing that room with another person. And increasing the ventilation in that space is also important. If they are not COVID positive, I would still consider trying to make it so that they don't have a roommate in that room. I know that's not always feasible, but consider then increasing the ventilation in that space. Those that are caring for those persons who are COVID positive, as we mentioned, as I showed in that slide, people have to wear, those that are serving those persons that are COVID positive need to wear an isolation gown, or one pair of non-sterile gloves. And I do want to take this time to say, not necessarily in your settings, but we've seen in other settings, people wearing double gloves or two gloves, taking off the glove, hand sanitizing the glove. We do not do that. That is not appropriate. It wasn't appropriate pre-COVID, and it's not appropriate now. So make sure to one pair of non-sterile gloves, removing the glove, hand hygiene on your actual bare skin. I just want to point that out. So COVID positive individuals who have AGPs, gown, gloves, eye protection, and then for those individuals, since they're having AGPs, if you have staff that are fit tested, they should wear a respirator if they are fit tested and as part of your respiratory protection program. So that's the guidance for positive individuals with AGPs, and no roommates, and increasing ventilation. Thank you. So that was very good transition to their next question, which is, there were two questions about this actually. Who is qualified to do fit testing for staff using N95? And does DC Health provide fit testing training to residential providers? I also just want to note that our nurse practitioner, our nurse educator, has done training for all staff that included in it PPE guidance that included a video about fit testing, but perhaps you could let us know
who's qualified to fit test, and does DC Health provide training on this?
Great, thank you. So we do not, DC Health at this time does not do fit testing. And we've had this question from many different settings. So we do not provide fit testing. We can provide references and resources that will help any facility, comply with the OSHA regulations for protecting your staff with for any respiratory hazards such as COVID-19. So in that OSHA requires that facilities that do have that create a respiratory protection program. So it's basically a written respiratory protection program as required by OSHA regulations. And in that, it kind of, part of that is really doing fit testing for respirators and other aspects. So we can provide resources, links to that. I'm happy to share that in the chat if I can pull it up. And then, but for fit testing itself, we do not do that. Those that are, who is able to do fit testing, one, as far as I'm aware, there is not, OSHA does not, from the regulation, require a special certification to do the fit testing. However, those who are doing the fit testing needs to understand how to do that process properly, because fit testing is really making sure that that respirator works. Meaning, I kind of liken it to going to the store, like Old Navy or Gap or wherever to buy pants. You want to try on those pants to make sure they fit. And that's part of, having respirators work, is that they need to fit the person who's wearing it. And after that, the person who has now been fit tested with this respirator needs to know how to properly wear it and check to make sure it still fits every time they wear it. So that's the seal check portion. So my analogy to that is I go to a store, try on different pairs of jeans, find the right size. That's fit testing. Then every time I put on those jeans, now that I tried it, I tried it on at the store and I bought it, every time I put it on, I make sure it fits before I leave the house in case I ate too much chips the day before, to make sure it fits. That's the seal checking part. So long story short, DC Health does not provide fit testing. OSHA regulations really outline what needs to be done on a facility level, meaning the respiratory protection part. What ideas I can provide is that other facilities who are asking about this, there are third-party companies that do fit testing. We don't have a recommendation we don't provide recommendations for third-party companies. We do know some folks also reach out to hospitals who have occupational health programs to get assistance from them. Those are some ideas that we've heard from the field from other facility settings.
So someone was asking if the PowerPoint can be available, can be made available to be posted on our website.
We can, I will make sure that we can, I'll take a see if we can do that. I have to clear it with, if it's going to be published, we have to
Right.
get it approved. But yes, I'll try to make that happen.
So the definition of a patient or resident care area include outside the home in the community?
So are you with the person being supported? So for example, if I'm with the person being supported and I'm going out and then I'm pushing them in their wheelchair, for example, the answer is you are in the same space as that person that you're supporting. I know that this has come up as a question before in terms of wearing eye protection while you're walking, in the parks or whatnot. Right now, this guidance is really for healthcare facilities as defined by what we discussed. So it doesn't cover when you're off the facility during a group activity, for example. But I would say that you should definitely wear universal masks around persons being supported. And if you need to be within 6 feet, really consider wearing eye protection when you are in your group activities, but we'll get that clarification because this guidance does not address that specifically.
So there are a couple more, but we had gotten a question earlier today that I want to make sure that we get to because it is, I think, so vitally important, which is earlier this week, DC Health met with all of our ICF providers to talk about infection control and all of their placements, and presented that people should only be going out to do essential medical appointments, and to what this question says is to delay non-essential medical appointments. They also said that virtual appointments should be done to the greatest extent possible. I want to clarify, and DC Health can, and I think that I'm certain DC Health and I are saying the same thing, which is whether an appointment is essential or not is a decision for the healthcare provider who's providing that care. So that if you, for example, have a quarterly visit with a physician for follow-up for a particular condition, and I believe I've said this several times, there needs to be a phone call to that healthcare provider to ask, does this need to be done on that schedule? Can this be done remotely? Is it essential that this occur? Putting off routine healthcare is not an option right now, and particularly making a decision ourselves that it's okay to put something off. It is the physician or the whatever healthcare provider who has recommended the particular follow-up. It's their decision. First, can this effectively be provided remotely? And secondly, is it essential, and is it something that requires you to come in and see me? And lastly, could they make a decision that, yes, it's important, but we could put it off for a few months? All of those are medical questions for the person who's recommended the treatment. And you need to consult with that person about how the treatment's provided and when it's provided, and it should be provided consistent with that. There's something else in this about, our health and wellness staff will ding people if they fail to follow through with a routine appointment. As I've said throughout this, there needs to be documentation that there's a conversation with the person recommending the treatment and that care is being provided consistent with those recommendations. And I expect DC Health, I know we've got Sharon as a panelist, Sharon Mevin. So if our communication is in any way different, and I don't think it is, all of us recognize, because, that slide I showed earlier, where the number of deaths was perhaps only 27, we don't want any, people haven't been dying from COVID, but we have had other deaths. It is essential that people be getting, that they get out safely for some exercise in the community, to walk around, to get exercise, that they get routine health care, that they be taking care of themselves. The guidance has been updated recently to allow for visitation so that their social needs can be met as well. Those connections with family can be maintained. Their physical health can be maintained. We want to protect people from COVID, but we also want to make sure that any underlying health conditions are addressed.
Hi, this is Sharon. Yes, Dr. Reese, we are in total agreement. Your physician is the one that makes determination if the medical appointment is essential. And I think it's important also to educate some of your physicians or healthcare personnel to let them know that the ICFs, and because they may not be familiar with the guidance, so let them know that there is a stay-at-home order for ICFs and ResHab, and that you need to know if this is essential for the health and safety of the people that you're serving.
So there's a question here. I find it unusual that fit testing is required for N95 masks, yet everyone is very hands-off about the issue. It seems like undue liability for the provider. I wish that this was not so ambiguous. We have been left on our own to figure this out, which many of us have done, but wish we could get clearer assistance.
I think so. This is Sarah Hawkins. I know that I think a lot of facilities are struggling, not just in this setting, in many settings, about fit testing, because in the past, pre-COVID, many of them did not have a respiratory protection program or regularly fit tested their staff. So I understand that that's difficult. Like I said, though, however, if I put some links in the chat that are good references, but if you had any questions, please feel free to reach out to us. We're happy to talk you through that process. And while right now DC Health doesn't do fit testing for your staff per se, we can certainly help you when you look at these links. If you had any questions about them, we can certainly answer any questions you might have after looking at that, or how to implement.
So then there's a question: if staff assist a person for 2 minutes with ensuring that CPAP is on properly, can they reuse the mask tomorrow? What is the lifespan of an N95 mask? Can an N95 be sterilized?
Great. So great question. CDC does have a very detailed link on respirators and what to do for different PPE capacity, but I will summarize that here. But there, if you wanted to read more, it is on the CDC website, and I can post that link in the chat like I did for the previous things. N95s, in the normal conventional capacity, if you had a lot of respirators, right, and you did not have a shortage, you should normally, what we do is throw that away after you use it. The next best thing would be to extended wear it, meaning every time you take off PPE, that increases your chances of contaminating yourself, right? So self-contamination. So if you can extend use the mask, that's better than taking it off, putting it on, taking it off, putting it on. If you're going to reuse a respirator, one, go with the manufacturer. If the manufacturer does not have a reuse amount, then the guidance is 5 times, 5 reuses. And that's not 5 days. I will clarify. 5 reuses means I put it on, I take it off because I'm going to eat. That's 1. Then I put it back on after I eat. I go and do something else. I take it off. That's 2. So 5 reuses. That's 5 times you can take it off. And then the way that you need to store that would be in a breathable container that to minimize cross-contamination of the environment, storing it appropriately. Again, CDC goes over this very specifically, but I'm giving a summary. 2, if the N95, even before those 5 times, becomes hard to breathe through, becomes visibly soiled or contaminated, you must discard of it. So that answers the lifespan question. And then, can N95s be sterilized? There are ways to decontaminate N95s, most of which are not going to be able to be done in your facility. So anything that you've seen on the internet, like spraying it or misting it yourself with hydrogen peroxide, not appropriate. There are very specific certain ways that N95s can be decontaminated. Like, for example, I think in the beginning of the pandemic, we had Battelle was doing this for free for facilities in the district. So that's one particular example of the certain decontamination that's available for N95s. But again, it isn't a pick and choose which strategy. It depends on how your PPE supply. If you had ample amounts of supply of respirators, you should use it the way we did pre-COVID, which is you should discard of it. If it becomes soiled and contaminated, you should not reuse it. If you need to extended use, meaning wearing the same one for extended period of time, is better, and then throwing it away at the end of the shift. If you had to reuse, that's the next step. And that's five taking off and putting on. That's the max, unless the manufacturer gives you something different. And in those instances, you must store, your staff should know how to store those appropriately in the appropriate container. And again, hand hygiene, hand hygiene, hand hygiene. When you reuse a mask, the front is contaminated. So it must be treated as such. So it's even more important to do hand hygiene before putting it on and after taking it off in those instances.
Hi, Daryl. This is Sharon. One question came up doing a survey that I'd like you to share the response to. If there is a individual who is being isolated because of being positive to COVID, what PPE should be discarded prior to leaving the room? I know you mentioned in your video that the gloves needs to be discarded, but what about the face mask?
So if you're caring for someone with COVID-19 in the room, and then my other colleagues are here too, including Nelson, but so he works also on the guidance team, so he can chime in. But face masks, unless it's visibly soiled, could be continued to be extended, as long as there wasn't an aerosol generating procedure that was done for that COVID-19 positive person when you were in that room. So you could continue to extend the use of that. If
was that
I know
hey,
hey Nelson.
Nelson. So was that the question? I thought that she was saying, should you remove it before you leave the room? Was that the question? Can we just clarify? Make sure we're answering.
Yes, the person is positive. The DSP is providing care for that person. Now the DSP wants to leave the client, the individual's room. Should they be discarding before they leave the room their face mask? But you said that you can continue to wear it.
Keep it on, and if you were going to discard it, do not remove your face mask in that person's room. Remove it after you leave if you are going to discard it. Let's say it was visibly soiled.
Right.
Oh, okay.
Well, thank you. We were actually at 1:05, so that was a very quick hour today. So I really want to thank you for sharing all that information. I think it's been very helpful. I hope it has been helpful to the community and our providers. And we will talk with everyone again next week.
Thank you. Oh, and I see one for indoor visitation. We can, if you have any questions, you can always email us in that email, or we'll be back next Friday and we'll answer any questions then for indoor visitation.